Hello, welcome to my channel, and here I am going to give you an update from my own presentation, female voiding dysfunction, that I'm going to share with you today. This is purely for non-neurogenic conditions. So first of all, I'm going to begin with take-home messages. The take-home messages that you are going to get out of this presentation are that all women with any type of lower urinary tract symptoms, irrespective of whether they are symptoms related to storage or voiding, that is urge incontinence frequency or anything, or uh, real voiding symptoms, all of them require evaluation for voiding dysfunction. Functional causes are much more common than actual urethral strictures in women, and urethral calibration is a highly unreliable way to decide for whether there is a need to dilate the urethra or need to fix the urethra by either dilatation or reconstruction. And in evaluation, we need a very judicious sequencing of urodynamics, MCU, and urethroscopy to complete the evaluation and finally categorize the kind of voiding dysfunction that we are dealing with. So let me begin. Who needs to be evaluated? What all can get identified on that evaluation? That means the differential diagnosis, what all that can we get, and how actually to evaluate, how to go about evaluation. So many times the obvious on the surface is not so obvious when we dig deeper. When we zoom in, we see the cracks, and there are many. There are many because the literature is not very clear about so many things in this aspect. And this is an opportunity for me to again reintroduce and emphasize on this book that we had published on the same subject. And this was published just because every time I had to dig into some papers, some publications, and all of us felt that there is a dearth of actual text in form of chapters where things are compiled in a better way. And this is actually a compilation. Please read this, recommend this to your people. So voiding dysfunction, as we know, is either poor urine flow or increased post-void residual urine, either both in combination or any one of them. We have to look for this in women with who complain with of voiding lower urinary tract symptoms. This is obvious. We will get a uroflow, but also in women with recurrent UTI. This is not so obvious. I'll tell you why. This is also required in women with overactive bladder without any voiding symptoms. Also in women with painful micturition. In women with stress urinary incontinence. The voiding symptoms in women are almost equally prevalent as they are in men. If we take age to age, if we match women and men, they are equally present. Women with recurrent UTI, 50 to 60% of such women have voiding dysfunctions. Women with overactive bladder, approximately 35 to 42, have bladder outlet obstruction depending on the definition used. There are so many definitions in the literature. 48% of women with suspected bladder pain syndrome have voiding dysfunction or bladder outlet obstruction. Although it is a very difficult thing to actually get urodynamics in real painful bladder syndromes, but many times uh, painful bladder syndrome is a diagnosis of exclusion, and pain is a symptom of bladder outlet obstruction, many kind of bladder outlet obstructions as well. So until unless we exclude BOO, we should not be going and saying that as painful bladder syndrome. Women with stress urinary incontinence, 13 to 15%, where uncomplicated SUI is suspected, but they have bladder outlet obstruction, and that has obvious implications because putting in a sling in such patients may lead to retentive complications, obstructive complications. And then bladder is said to be an unreliable witness. This is a very popular statement. Uh, and why I say so? Because we see only storage symptoms or voiding symptoms, and that is how we have categorized it. We cannot look at them as just one entity. Storage symptoms cannot be absolutely separate from voiding symptoms because dysfunctions have both things in common. There is an overlap. And if we look at this, then all female lower urinary tract symptoms as a whole, there is a subset of them that have female voiding dysfunctions. Rest of them will have only overactive, pure overactive bladder, maybe. And out of all voiding dysfunction, this will have bladder outlet obstruction and bladder underactivity as well. So there will be a subset who has bladder outlet obstruction. And out of all this subset, there is a small subset who has female urethral strictures. Rest all of them are either uh, functional obstructions or obstructions because of prolapse or because of sling or otherwise. So if you look at all female voiding dysfunction, female urethral stricture is a very, very small subset out of them. But when we evaluate what all should we get, we should be able to differentiate between obstructed or underactive bladder is one. We should be able to differentiate between anatomical obstruction versus a functional obstruction. We should be able to know that whether we can offer this lady a therapeutic alternative or something just for palliation without cure. The differential diagnosis on evaluation of voiding dysfunction, what we can get is urodynamic bladder outlet obstruction, which can be either functional. In functional, it can be dysfunctional voiding, which is the most common, poor relaxation of a pelvic floor, which is sort of subset of the same spectrum, dysfunctional voiding. And then there is obstruction at the bladder neck, primary bladder neck obstruction. So these two are at the level of pelvic floor or external urethral sphincter, striated thing. And this bladder neck obstruction is at the level of bladder neck here. Then anatomical can be post-sling obstruction, and it can be because of UV prolapse, which is causing obstruction, or it can be because of female urethral strictures. Then on the other hand, there is detrusor underactivity, which can be hypocontractile or totally acontractile bladder, or detrusor hyperactivity with inhibited contractility. So urodynamic BOO has to be differentiated from detrusor underactivity, and functional has to be differentiated from anatomical. The first differentiation requires urodynamics. This requires an MCU to know the level of it, and if you are privileged, then if you are having a video urodynamic setup, then both of them can be done together as well. And identification of female urethral strictures actually requires cystoscopy. Again, the obvious on surface is not so obvious when we go deeper. Let us know why I say. All this, these three things require very judicious sequencing of calibration, urodynamic, MCU, scopy, what to bring in first and what to bring in later. But first of all, calibration. Let us clear this thing. That calibration, the caliber of a female urethra, what is abnormal? Many researchers have said different calibers below which they have claimed that it is abnormal. And then spasms at pelvic floor level may be more pronounced in functional obstructions, and which can give a false impression of stricture and can lead to unnecessary dilatation. So in my opinion, any urge to dilate a previously undilated urethra, I mean that is untouched urethra earlier, should be confirmed on urethroscopy, whether that is really narrow or not, whether it requires a dilatation or not. You won't be dilating a functional bladder outlet obstruction. Just like we do that in males also. We dilate only strictures. We do not dilate the neck obstructions or other things. And why calibration is unreliable? Because in this paper from Jipmer, they say even urethra which are can be calibrated, that also may be having stricture. So that is a controversial aspect. I'm not going deeper into it, but definitely calibration is unreliable till things are sorted out. Now our main focus will be how to use all these three things: urodynamics, MCU, and urethroskopy to complete our evaluation. First, coming to urodynamics, because urodynamics bladder outlet obstruction definitions are so many. And mm, they are so many because earlier bladder outlet obstruction was defined on urodynamics in men, and then the cutoffs somewhat arbitrarily were defined in women. They were set to around 50 centimeter ped Qmax, which then was thought that that is too high, and then it was brought down. It was Nitti and colleagues who finally worked on this, and very subtle kind of obstructions on uh, after placing a sling for uh, placing a sling for incontinence, stress incontinence, when it was found that these ladies, if they have very subtle, purely obstructive voiding symptoms or little voiding symptoms, uh, but they started after placement of sling, whether to remove the sling or not, to de-obstruct or not, whether there is an obstruction or not. So then MCU came to their rescue, and when they confirmed that there is a bulge in the proximal urethra on MCU, so all those urodynamic values were then considered obstructive, and because really there was relief after uh, doing away with those slings. So that is what brought the values, and it is now understood that any PDET at Qmax above 20 centimeter of water in women should be considered as obstruction. There is a nomogram also, but it has been poorly standardized as of now. Uh, it can tell you probability of obstruction is not there almost with certainty, and more than likely this, but this area in between where bladder outlet obstruction index in female is between 5 to 18, that is too unequivocal, very broad area. So big gray area is there. So in urodynamics, we know that there is very high pressure, very poor flow. Here we know that it is obstruction. This is bladder outlet obstruction. Similarly, here very high pressure, very poor flow. This is bladder outlet obstruction, but it is in conditions like this where the graph doesn't go very high, and P rate of at Qmax is around say 20 22 centimeter of water. Whether should we consider it as obstructive or underactive? So it is here that that the MCU or the voiding film becomes very important. If it is showing a bulge, convexity, then it should be considered as obstruction. But not every bulge means that there is an intraluminal obstruction. All these MCU pictures, voiding films, have dilated proximal urethra, but this is a stricture, this is not a stricture. Again, this one is a stricture, this is not, this is a stricture, this is not a stricture, this is also not a stricture, and this is a stricture. So these are two scenarios. This is bladder outlet obstruction on urodynamics, uh, proximal bulge, convexity of urethra, and a panurethral stricture. And a similar picture here in the lower panel, bladder outlet obstruction on urodynamics, bulge, and pristine clear urethra. This is a figure again from our book. I'll be referring to the book again and again. So visual demonstration of an anatomical luminal narrowing on urethroscopy is the gold standard. There is no doing away with it. And how to do that is if we do a conventional thing where we use a 30-degree scope with a normal conventional cystoscope sheath, then by the time we enter the urethra, most of the distal urethra is already traversed. By the time the entire scope uh, sits inside without dripping of irrigant fluid out of the urethra. So it is not able to actually blow and see the urethra from the outside, and maybe very distal strictures get uh, get dilated by the time we enter the urethra completely. So best is to have something which does not have a hypospadiatic peak at the tip, and where irrigant goes in from the very start and 0 degree where we can see the urethra from here. Um, Look at these two in the same urethra. Uh, this one, first one, is with a 30-degree scope, conventional cystoscope sheath. And look at the difference what you notice with an OIU sheath with 0 degree lens. This blows the urethra and any narrowing stands out. Then many people say that pediatric cystoscope should be used for assessment of female urethral stricture. I differ. It should not be used because when a pediatric scope traverses through that luminal narrowing, we won't even know. Look at this. I've used a pediatric scope. This is a 6 French pediatric scope. Can we diagnose? Can we certainly say that there is a stricture? No, there is a doubt, but we can't say. And in the same lady, look at it here. How OIU sheath, just keeping it at distal meatus, just inside the meatus, how it blows it up, and any luminal narrowing is stands out. So pediatric scope can be used for assessment. Once you have diagnosed the stricture, you can go in and see the extent, but it should not be used to say that there is a stricture. So a dedicated step of urethral inspection is what is important in any woman where there is a suspected urethral dilatation. Uh, it should be, it is my urge that you should document a stricture before subjecting her to dilatation, because once you dilate and once the discharge says urethral dilatation, there will be some relief, of course, for some time, but functional obstructions do not get relieved for very long. Within 10-15 days, that stretching comes back, but stricture stays relieved for a longer time. So but once a label is stuck, then there is no going back. Everybody will keep on dilating, and one day an iatrogenic stricture will be formed, and we will not know what actually to do with that lady. And then there is something about primary bladder neck obstruction. There is a challenge there. First of all, uh, as I told you, the urodynamic obstruction is difficult to define, but here in primary bladder neck obstruction, we cannot even expect dilatation of the urethra. So we have to know similar MCU pictures, similar voiding films, but obstruction is there or not can only be seen on urodynamics. So that is where it becomes important. Look at this picture. This is urodynamic bladder outlet obstruction, and this is patient has not voided, is not voiding, but if we have a video urodynamic, then it will be certain that the obstruction is at neck. Similarly here, not so high pressures, but the bladder is not opening. Neck is not opening on voiding. So this is primary bladder neck obstruction. But look at it here. Neck is not opening, but here the urodynamic is not showing any increase in PDET as well. So this is not outlet obstruction. This is an underactive bladder. So underactive bladder and bladder neck obstruction both will have a similar kind of voiding picture on MCU or video, but there the pressures become very important. If there is not in any increase in pressure at the time of voiding, then uh, it is not bladder neck obstruction. So finally, all these take home messages, you can take them home. That is all. Thank you so much.